Assalamualaikum everyone, welcome back to this channel. This is me Ali Wahid and you are on the channel of Medicare. So as you know that we have started the lecture over the chemotherapy. So this is our syllabus and we have started the chemotherapy here. We have discussed a lot of antibacterials that we use in the case of cancer. We discuss antifungals, antivirals, antiprotozoal, malarials, anti-antibiotics, anti-elimentics and anti-leishmanics. Last is the anti-neoplastic drug or the anti-cancerous drug. So this is the topic that we are gonna to start today. So let's start this chapter. So this all the information is from the Lippincott book. So this is the Lippincott book chapter 35 from your book, and the first topic is just an overview. In this overview they just have given that how much patients are suffer from the cancer disease worldwide. So this is just an overview. It has not any conceptual details written in this paragraph, so this is completely waste of time to discuss this whole the things. You can read it out by your own self. We are gonna to start the major thing, which is about the principles of the chemotherapy, that why we are giving the chemotherapy and how it works, how it is gonna to work. So let's study it, what's written in the book, and then I will give you a short explanation of it. First, they explain that the cancer chemotherapy strive to cause the lethal cytotoxic events or apoptosis in the cancer cells. So just the similar thing they are explaining, that all your anti-cancerous drug, they are cytotoxic. Cytotoxic mean, the word cyto mean cell and toxic mean they are toxic for the cells. They are going to kill all your cancer cells that can arrest the progression of tumor growth. So they are decreasing, they are stopping. Arresting mean to stop the progression of tumor, to stop the growth of tumor inside your body. This attack is generally directed toward the DNA, so it is directly inhibiting the DNA of your cells, and also it block all the metabolic sites that are essential for the cell replication. For example, availability of purines and pyrimidines, because they are the building block of your DNA and RNA. So this is our goal of cancer therapy, that it is gonna to kill your cancerous cell. And how? By arresting or inhibiting the DNA. And how DNA is inhibiting? We decrease the purines. Here we decrease the formation of purines and pyrimidines. Both when inhibited, then the DNA and the RNA of cell will not form, and as a result your cancer cell will die. But it is not only going to kill your cancer cells, it has also the ability to kill all your normal cells. So that's why it can destroy the normal cells that are in the surrounding of the cancer cell, and that's why the cancer cells are very cancerous. Drugs are very dangerous for us. So this was the thing explained in this paragraph. Now read more from it. So ideally the anti-cancerous drug should interfere only the cellular process that are unique to the malignant. So they are explaining that a ideal cancer drug is the one who only kill the cancer cells. This is the ideal state, that it should only kill cancer cell, it should not destroy our normal cell. But this is not the reality. In the reality, your cancerous drug also kill your normal cells. So they have explained, unfortunately, most of the traditional anti-cancer drug don't specifically recognize the neoplastic cell. Neoplastic cells are the cancerous cells, but rather kill all the other proliferating cells, all the other kind of normal cells, both normal and the abnormal cells. Therefore, almost all the anti-tumor agents does have a steep dose response curve, both therapeutic and toxic effect. The newer agents are being developed. So they are explaining now in the modern age, some newer agents are also discovered that only inhibit the cancerous cells. They attack on our own immune system, and then they only kill our cancerous cells, not on our normal cell. So this is the advancement in the cancer therapy. Next is, while this strategy is showing great promise of adverse effect are due to, and the major adverse effect is our autoimmune toxicity. So we, in this lecture we will also study what are the major adverse effect of most of the anti-cancerous drugs. So they have mostly most of the cancer drug have the adverse effect related to our immune system. Mostly they are autoimmune toxicity they can cause. As compared to myelosuppression, this is a second most important adverse effect caused by the chemotherapy agent. Next is the treatment strategies. We will discuss how we are going to treat our cancerous patient. And first, our goal of treatment is to be a free survival, is to make the patient free from this disease, as it is a long term treatment, because the patient because cancer is not a small disease, a acute disease. This is a chronic state, and the patient given the drug, not only a single drug, it is given, it comes with a combination of the drugs. So that's why it is a long term, but these drug can improve the chances of survival in the patient. So a true curative requires the eradication of every neoplastic cells. If curative is not attainable, then, so let's study this paragraph through the shortest way. So we are studying the treatment strategies. So the first treatment is curative treatment. In curative treatment, we give the patient all the anti-cancerous drug, and we make her survival possible. Second treatment is palliative. Palliative, this is the treatment, it is given when curative is unattainable, mean the patient cancer is become more worsen and more progressive, that now the curative treatment is cannot be given. Now, to stop the cancer and to extend the survival and to maintain the quality of life, we start the palliative care and to symptomatic relief, so that all the symptoms of the cancer should be relieved. Like if I give you the example, a patient, we have given her a long therapy of the anti-cancerous drug, but now she is not responding to that cancerous drugs. We have tried every class of the anti-cancer drug, but it's not gonna to eradicate all the cancerous cells. Then we start, then when the patient reach to the last stage of the cancer, then we start the palliative care, in which we give the patient the just to symptomatic, like if a patient, if this cancerous patient has the vomiting, we give her the anti-vomiting agents. If this patient has some pain, then we will give opioids to him, or anti-analgesic effects, we will provide this kind of drugs to him, just to relieve her symptoms, or to improve the life, or to extend the survival as much he can. But the for the cancer, it's such a dangerous disease, the patient has some weeks or some months. So this palliative care for the patient is just for some days and some weeks, and even for some months. Okay, the third therapy that we can give is through the radiation. We put the rays, and the rays are only for decreasing the size of the cancer. These radiations don't completely destroy your cancerous cells. We put particular amount of rays over that area where the cancerous cells are, and just we decrease their size. We can completely remove that cancer from that side, but we have to provide the more rays to our body. And when we provide immense rays to our body, the surrounding the normal cells can also be damaging to that area. And every body part is so special, and every organ present in that location is so special, that these rays can also destroy or completely cause the failure of any organ. So that's why we just put a specific amount of rays, just to decrease its size and to improve the survival of patient. Next, we can do the surgery. So both radiation or the surgical treatment, they are called adjuvant treatment. Okay. So through the surgery, we remove all the cancerous cells. We target the micrometastasis. Micro means small and metastasis mean cancerous. So micrometastasis they are removed through the surgery. Next therapy is through the neoadjuvant, mean before surgery we shrink the size of the tumor. So this type of therapy is called neo adjuvant. Last is the hormonal therapy, in which we use some drugs that block the hormones. So some hormone sensitive cancers are there, like the breast cancer and prostate cancer. So for these kind of cancer we block some hormones so that cancer should not be progressively increase. Okay guys, so now we are going to start our text reading from the book. So here we are discussing the goal of the treatment here. So here they have explained that the goal become control uh, of the disease to prevent from the cancer and enlarging and spreading. So we have to stop the spreading and enlargement of our cancer, and to extend the survival here, maintain the quality. Same thing they have explained here. Near the normal existence. So now they have explained that okay, so they have just explaining that what is the goal of your cancer is, how to treat it. Then indication for the treatment is that you have to attack the micrometastasis by following the surgical or radiation process. This is called adjuvant chemotherapy, given prior to the surgical process to attempt to shrink the cancer. We referred as neoadjuvant chemotherapy. Same thing that I have explained here. So tumor susceptibility and the growth cycle. The fraction of tumor cells, they are replicative cycle. Growth factors have influenced the stability in most cancer therapeutic agent. Rapidly dividing cells are most sensitive to the chemotherapy agent. So actually, whenever the cell divides, it needs some growth factors. So at that site where the growth factors are more, these all the cancers, all the anti-cancer drug, they affect at that area. Because the cancer cells, they are also the rapidly dividing cells. So that's why it act on that area more particularly. So that's why the rapidly dividing cells are generally more sensitive to chemo drugs, whereas slowly proliferating cells, proliferating mean dividing. So those cells which slowly divide, they are less sensitive to the chemotherapy or the chemo drugs. In general, non-dividing cells, those cells which are in G naught phase, they usually survival the toxic effects of many chemotherapy agent. Mean those cells which don't divide, which are in G naught phase, the chemo drugs have no effect on them. So these kind of things are explaining here. Next they have explained some sun cycles, and some drugs are specific to that. So actually every cell has a cell cycle, and it has some phases like G naught phase, G1 phase, G phase, M phase. You have studied all these phases in your previous classes. So both normal cell and your tumor cell and your cancer cell, they have growth cycle, they have a cell cycle, they have G1 phase, G2 phase, S phase. However, the number of cells, there are various stages of the cycles may differ from the normal or neoplastic tissues. The chemotherapeutic agents are effective only against the replicating cells. They are explaining again and again that the chemo drug are only sensitive to that area where more proliferating cells are there, where rapidly dividing cells are present. Okay, so where we are, yeah, so that those cells which are dividing are said to be cell cycle specific. So those drugs that affect a cell in a rapidly dividing cell, they are called cell cycle specific, while the other agents that are cell cycle non-specific. Although the non-specific drug generally they have greater toxicity in cycling the cell, they are useful against the tumors and have low percentage of replicating cells. Okay, so next is the tumor growth rate. How what is the rate at which the tumor is growing? Okay, so growth rate of most solid tumor is initially rapid. So it is fast at the initial state, but the growth is usually decreasing as the tumor size increases. So just as the tumor size is increase, its speed is a little bit down here. Sorry, increase there. So sorry for that. Initially, it is rapid, but as the tumor size increases, it decreases. Okay, so this is due to our deficiency of nutrients or oxygens. कम हो जाते हैं. That's why lack of blood circulation there. Tumor burden is reduced from the surgery here, and the tumor burn and the radiation and the use of cell cycle non-specific drug promote the remaining cells into more active proliferation, increasing the susceptibility of cell cycle specific chemo drugs. Okay, so just the first line is important, which is that your growth rate of tumor is initially rapid, but as the tumor size increases, this growth rate is decreases there. And why it decreases, they have given the reason: because the nutrients, because the oxygen, because the blood supply, all of these things decreases, and the burden on the tumor cell increases. That's why its growth rate decreases. Okay, so this was the important thing written here. So please highlight that these things within your book so that you can remember that this is important to study here from here. Okay, so we have discussed it. So moving on to the next page here. So at that page they have explained some diagrams that how your DNA is formed, RNA is formed, because anti-cancerous drug, they are inhibiting the DNA and RNA through inhibiting the synthesis of purines and pyrimidines. So that's why we are discussing it. So I'm gonna to just a little bit zoom it out so that you can clearly see what words are written here. So how your purines and pyrimidine is synthesized. So first of all, this enzyme, okay, so how your purines and pyrimidines is going to synthesize RNA and DNA and some proteins. Okay, how now start is through these uh, nucleotide bases. First enzyme is 6-mercaptopurine thioguanine. It inhibits the de novo synthesis of purine, inhibits the nucleotide interconvenient. Then it make ribonucleotides. Next drug it is, which is methotrexate. So actually it inhibits the enzyme here which work at that side, and the enzyme name is dihydrofolate reductase, leads to the inhibition of purines and DMT synthesis. Next, this is the drug name which inhibit the formation of deoxynucleotides. Okay, next is this drug that act on this state. Okay, so these deoxyribonucleotide, which is the DNA, it forms the DNA. This is a drug which inhibit at that side. Next drug is that we will discuss all of these agents, all of these drug. Okay, that inhibits the process of formation of RNA and DNA. Okay, so moving on to the lower okay, so in this graph they have explained the time and the tumor cell burden, how through how much rate the tumor cell grows, it here, and the time is here. So they are actually explaining you that the how our tumor grows. So this is the initial state, and you can see the curve here. It is rapidly increase at the time passes, it's rapidly increase the cell number. So this is the number of the tumor cell that increases. Okay, and its weight is increases. Okay, so always the tumor or the cancerous cells grow in the log. Okay, as the bacteria grow, its concentration increase in the log. Similarly, the tumor cells or the cancerous cell, they also increase their number in the log phase. So they are increasing. At this point their mass is about 1 mg. So this is 10 to power 6. It is the 1 mg of tumor. So 1 mg of tumor from here, then more it increase, cell number increase, and then it became 1 gram mass. So this number is around 10 to power 9. This at this point we have 10 to power 9. So they have caused significance. 1 gram is tumor mass. So total 1 10 to power 9, 10 to power 9 cells is the smallest tumor burden. This is the smallest tumor. We have many other largest tumor, but the tumor is of 1 gram when it is physically detectable. Detectable means that we can see it. Okay, so it's mean कि यहाँ से हमारा कैंसर प्रोड्यूस होना शुरू हुआ, इसके सेल की ग्रोथ हुई और यहाँ पर हमारे लिए ये विजिबल नहीं था, इसलिए इस जगह को उन्होंने हाईलाइट इतना नहीं किया. ये वाली जगह हाईलाइटेड है क्योंकि यहाँ पर हमें विजिबल है हमारा कैंसर. बट एट दिस स्टेज जब ये अपना ग्रो कर रहा है, इट इज़ undetectable for us. That's why whenever the mass or the cancerous mass is become of 1 gram, then it is visible to us, otherwise we cannot detect it. Okay, we have not kind of instrument here for us. So 10 to power 9, they are totally 1 billion cells. Okay, so 1 gram of tumor is equal to 1 billions of cells. They represent the tumor weight of 1 gram and about the size of small grape. जितना एक छोटा अंगूर का दाना होता है ना, उतना साइज होता है सबसे पहले ट्यूमर का. ठीक है. क्लिनिकली सिम्टम्स यूजली फर्स्ट अपेयर एट दिस स्टेज. सो इस स्टेज के बाद आपका सिम्टम्स और साइन आना शुरू हो जाते हैं एंड देन यू विल डिटेक्ट यू हैव सम ट्यूमर. Okay, so then they have explaining to us. Okay, now you see the graph here. So now when the mass become reached to 1 kg, 1 kg is at that side, then after that it will be the death. So the duration is between 1 mg and 1 kg. When it become 1 kg, after that the death will occur. Okay, the body cannot bear the weight of the tumor more than the 1 kg. Okay, so then this kind of graph they have explained. So cancer cells become increasing less responsive to the treatment. So ये यहाँ पर क्या हो रहा है कि हम ट्रीटमेंट दे रहे हैं बट कैंसर सेल लेस रिस्पॉन्सिव होते जा रहे हैं. पहले रिस्पॉन्स उन्होंने किया नंबर सेल का नंबर डिक्रीज़ हुआ, बट देन इट नॉट रिस्पॉन्सिव. देखा है कितने कम सेल डिक्रीज़ हुए हैं. सो उसका भी रिजल्ट डेथ होता है. सो अब इस स्टेज पे हम पेशेंट को कौन सा ट्रीटमेंट देंगे? प्लेनेटिव ट्रीटमेंट. प्लेनेटिव ट्रीटमेंट हम पढ़ के आए हैं कौन सा ट्रीटमेंट है कि इनिशियल रिमिशन आर ट्रांसलेंट मीन नॉन रिस्पॉन्सिव and the symptoms are reoccurring. Means we have given all the anti-cancer drug to the patient, but the patient is become unresponsive and the symptoms are reoccurring again and again. So then we start our planative treatment. Survival is extended, but the patient eventually dies due to disease. Okay, so just to increase the survival, we give antiemetic drug to the patient just to stop the vomiting and let the patient to survive for some more days, for some more weeks, and then eventually the patient has to die at that side. So this is the patient symptomatic, and below this area the patient is asymptomatic. So now you see that how much less time is between the patient death and the patient symptomatic care. Here the symptoms appear and here the death of the patient occurs. So there is very less duration between it because the cancer cell they progressively increase in such a high rate that we cannot being able to cure it. So now they have explained that at that site, when we detect 1 gram mass and then we detect it and then we move toward the surgery, we do the surgery of that patient. Now the cancer cell decrease, their cell size decrease because now we give the treatment to them. Okay, and this is this curve it represents the treatment with the anti-cancer drug. We give the anti-cancer, how the cancer reduce, this is explained here. So first we discuss the curative chemotherapy here. Okay. So your solid tumors such as testicular carcinoma, it is also called a tumor. So tumor burden is initially reduced by the surgery or radiation. तो हमने यहाँ पर सर्जरी की या रेडिएशन की और वो ट्यूमर बर्डन यानी उसके ग्रोथ रेट को कम किया. So the treatment of liquid micrometastasis continue after the clinical signs of pneumonia have been disappeared. ठीक है. They have explained that we will give drugs to the patient no matter her signs of cancer are disappear, but we have to give the all the kind of drugs to that patient because it's really important, because at this state the patient is asymptomatic, no symptoms, but he still has cancerous cells, he still have the cancer cells here. So that's why we should not stop the drugs given to the patient. Okay, next thing explained here that disseminated cancer such as leukemia, which is curative therapy, combination drugs of chemotherapy reduce the chances of drug resistance. So that's why we give the all the chemo drugs in combination. I have explained to you that you cannot give only one drug to a cancerous patient. You give a combination of whole drugs, whole classification to the patient, because it's really important to stop the drug resistance. So resistance is also occurring here, and how it occurs I will explain it. So each drug is chosen to have different cellular sites of action, having different cell cycle specificity, so that every drug is trying to kill that cancerous cells, and then we will efficiently kill all the cancerous cells. Each drug is chosen to have different organ toxicity. Okay, so these all the things are explained in this diagram. Okay, next they have explained some treatment regimes and scheduling of it, how the cancer cells grow in the log kill phenomena, how we kill it, and then some pharmacological and treatment protocols, combination therapy, and why we are giving combination therapy. And then they have explained the resistance, which I will told you how the resistance develops, and some common adverse effect of all the chemo drugs, and then how to minimize the adverse effect, and then tumor treatment induced tumors, and then in the next lecture we start the anti metabolites. Okay, so now before discussing the treatment protocols and discussing this page, I am discussing the short overview about the cancer. So it's really important to discuss what is cancer and what are the terms related to cancer, because in the next all the theory we will discuss the cancer and we will call the cancer through various names, and you should know about the every name. So that let's start it. Okay guys, so this is the explanation about the cancer is. So cancer is also called neoplasia and neoplastic diseases. What is neoplasia? It is derived from the Greek word mean new growth. So it is defined as abnormal proliferation of cells result in neoplasm formation. So cancer is a disease in which your cells abnormally proliferate, abnormally divide themselves, and they form neoplasm, masses of abnormal cell growth they form, and this is called neoplasia. So neoplasia is the other name of the cancer. Some neoplastic diseases, they are the group of diseases that are characterized by three things. First thing is aggressive growth, means unregulated cell division will occur. The cell will divide without any regular pattern. They aggressively divide themselves and they become cancer. Second property is invasiveness. They invade the other surrounding tissue. They also begin to destroy our surrounding tissue. Okay, so that's why the cancer is more dangerous, because it also begin to destroy our normal cell. And third state is metastasis, in which your cancer will spread into your whole body. So these are the three things that is promoting the cancer. Example of neoplastic diseases is the benign neoplasma and malignant neoplasma, and like the uterine fibrosis and the lung cancer. They are the lung cancer. It occurs very rapidly because it is malignant. and benign neoplasma is the uterine fibrosis. Then discuss what is neoplasm. Actually, it is the abnormal proliferation of the cell, abnormal tissue mass formation. Neoplasma has one, two, three, four types. Okay, first type is benignant neoplasma. It is non-cancerous. It is non-cancerous, mean it is not a cancer, but still it is a abnormal cell division. Okay, it is non-invasive. We consider a cancerous cell, it has three things. जो भी सेल कैंसर होगा उसके अंदर तीन चीज़ें हो रही होंगी. एक होगी अनरेगुलेटेड सेल डिवीजन, दूसरा वो इन्वेड करेगा सराउंडिंग टिश्यू को, और तीसरा वो स्प्रेड होगा. अब बिगनिंग न्यूप्लाज्मा में हम कह रहे हैं ये इस तरह का एक एबनॉर्मल टिश्यू मैस है जो नॉन इन्वेसिव है, मतलब वो सराउंडिंग के टिश्यूज़ को कुछ भी नहीं कह रहा. ठीक है, और वो लोकलाइज है, एक ही जगह आई, मतलब वो मेटास्टेसिस भी नहीं कर रहा, वो स्प्रेड भी नहीं हो रहा, और वो स्लोली ग्रो कर रहा है, रैपिडली भी ग्रो नहीं कर रहा. मतलब तीनों चीज़ें जो हमारे एक कैंसर होने की निशानियां थी उसने तीनों को पे ऊपर पूरा नहीं उतरा. सो इसलिए ये नॉन कैंसर है. ना वो सराउंडिंग की टिश्यू को इन्वेड कर रहा है, ना वो स्प्रेड हो रहा है, ना वो मेटास्टेसिस कर रहा है, वो एक ही जगह पे लोकलाइज है, और ना वो फास्टली ग्रो कर रहा है. कैंसर की ये खासियत है कि वो रैपिडली ग्रो करता है और सराउंडिंग के टिश्यू को भी इफ़ेक्ट करता है, और वो एक जगह नहीं रहता, फैलता है वो, और रैपिडली ग्रो करके फैलता है. ठीक है, अब बिगनिंग न्यूप्लाज्मा में क्या है कि सब कुछ उल्टा हो रहा है, ना वो सराउंडिंग के टिश्यू को नुकसान पहुंचा रहा है, एक ही जगह लोकलाइज है, फैल भी नहीं रहा, और ग्रो भी स्लोली कर रहा है. तो ये नॉन कैंसरस है. ये एबनॉर्मेलिटी तो है बॉडी के अंदर, ये एबनॉर्मल सेल डिवीजन हो रही है, लेकिन ये कैंसर नहीं है. ठीक है, अब आपको पता चला कि हर एबनॉर्मल सेल डिवीजन को कैंसर नहीं कहते. ठीक है, कैंसर उसे तब कहेंगे जब वो स्प्रेड भी हो रहा है, जब वो रैपिडली डिवाइड भी हो रहा होगा, और जब वो सराउंडिंग के नॉर्मल सेल को भी इन्वेड करना शुरू कर देगा, खाना शुरू कर देगा. ठीक है, सेकेंड टाइप आ जाती है न्यूप्लाज्मा की, पोटेंशियली मेलिग्नेंट न्यूप्लाज्मा. ये कैंसरस बन सकते हैं, दे मे बिकम कैंसरस, बन सकते हैं कैंसरस. तो ये वो न्यूप्लाज्मा होते हैं डैट हैव नॉट येट इन्वेड, कि वो इन्वेड नहीं करते और नॉट मेटासाइज, बट मे बिकम मेलिग्नेंट ओवर द टाइम. ठीक है, उन्होंने कहा है कि ये इस तरह के कैंसर सेल्स होते हैं जो अभी जो स्टार्ट में इन्वेडिंग या मतलब सराउंडिंग के टिश्यू को कोई नुकसान नहीं पहुंचाएंगे और नहीं फैलते, लेकिन जैसे जैसे वक्त गुजरता है ये स्प्रेड होना शुरू हो जाते हैं. ठीक है, इसलिए इसने कहा हमने पोटेंशियली मेलिग्नेंट न्यूप्लाज्मा. जैसे एग्जांपल दी ट्रिट्रोमास की, डिसफेनिया की, और सर्विकल इंट्रा एपिथेलियल न्यूप्लाज्मा. अच्छा, इसकी भी एग्जांपल थी फिब्रोमा और लिपोमा. ये है फैट टिश्यू ट्यूमर, सिर्फ फैट टिश्यूज़ हैं. अब फैट टिश्यू कभी भी फैट है, ठीक है, ये कभी भी आपकी बॉडी को नुकसान पहुंचाएगा नहीं, ये कभी भी सराउंडिंग की टिश्यू को नुकसान पहुंचाएगा नहीं, ये कभी भी फास्टली ग्रो नहीं करता, स्लोली ग्रो करता है. सिमिलरली डिस्प्लेशिया या इंट्रासर्विकल इंट्राएपिथेलियल न्यूप्लासिया में भी कोई इस तरह की चीज़ नहीं होती. थर्ड टाइप आ जाती है मेलिग्नेंट न्यूप्लाज्मा, और ये कैंसर है, ये सेल कैंसर है क्योंकि ये रैपिडली ग्रो भी करेंगे ये वाले न्यूप्लाज्मा, ये इन्वेसिव भी होंगे, ये सराउंडिंग टिश्यूज़ को भी नुकसान पहुंचाएंगे, और ये मेटास्टेसिस, दे आर कैपेबल ऑफ मेटास्टेसिस, तो ये स्प्रेड भी हो सकते हैं. तो ये तीनों कैंसर की शर्तों पे अमल करते हैं. सो इनकी एग्जांपल में कार्सिनोमा, सार्कोमा, ये दोनों वर्ड्स हैं कैंसर को बुलाने के लिए. सो मेलिग्नेंट जो वर्ड है ना, ये दो वर्ड से ड्राइव हुआ है, एक माल और एक जीनस. माल का मतलब है बैड और जीनस का मतलब है बोन, मतलब बैड बोन. Okay guys, so the fourth type of neoplasma is the frankly malignant. So they are also cancerous cells, they are also rapidly growing, invasive and metastasis. Its example is hepatocarcinoma. अच्छा बच्चों, उसके बाद हम बात कर लेते हैं ट्यूमर्स की. सो व्हाट आर द ट्यूमर्स, व्हाट आर देम. सो अ ट्यूमर इज अ न्यूप्लाज्मा दैट फॉर्म अ डिस्टिंक्ट mass and the swelling. A tumor and the neoplasma, they are simultaneously, but not all the tumors are न्यूप्लाज्मा. ठीक है, उन्होंने कहा कि ट्यूमर्स और न्यूप्लाज्मा ये एक ही चीज़ है, दोनों एक दूसरे के सिनोनिम्स हैं, एक ही चीज़ है, बट सारे, बट नॉट ऑल द ट्यूमर्स आर न्यूप्लाज्मा। सब ट्यूमर्स को हम न्यूप्लाज्मा नहीं कह सकते, बिकॉज सारी स्वेलिंग, मतलब कुछ स्वेलिंग होती है जो इन्फ्लेमेशन से हो गई है। अब मैं उसे भी क्या, मैं उसे क्या मैं उसे न्यूप्लाज्मा कहूँगी? क्या मैं उसे ट्यूमर कहूँगी? क्या मैं उसे कैंसर कहूँगी? नो। ठीक है, मैं आपको एग्जांपल देती हूँ कि उन्होंने क्यों ये कहा कि सारे ट्यूमर्स न्यूप्लाज्मा क्यों नहीं होते। कि हमें एक्नी होती है, एक्नी के बाद हमारे क्या होता है कि दैट पार्ट स्वेल्स। तो क्या आप उस स्वेल हुई हुई जगह को कैंसर कहते हैं? नो, इट्स स्वेल ड्यू टू इन्फ्लेमेशन। सो इट्स मीन हर स्वेल हुई हुई जगह ट्यूमर नहीं है। यस, हर स्वेल हुई हुई जगह न्यूप्लाज्मा नहीं है, लेकिन जितने भी ऑल द न्यूप्लाज्मा दे आर ट्यूमर्स। ठीक है, जितने भी न्यूप्लाज्माज हैं, एबनॉर्मल सेल डिवीजन्स हैं, उन्हें ट्यूमर हम कहेंगे। चाहे वो कैंसरस है या नहीं है, हमें इससे फ़र्क नहीं पड़ता, लेकिन वो ट्यूमर है। ठीक है, so I am, rewriting it again so that you can clearly see what is written here. Okay, so this thing is explaining here. So now our tumor has two types. Okay, so our tumor has two types. First is the malignant and second is malignant. So their difference is that differentiate. Malignant, they are well differentiated. They are just look like our normal cells. They have no difference between the normal cell and the cancerous cell. They still has a tumor. Like if you see a malignant skin tumor, you will see that the cancerous skin cells and your normal skin cells, they are just looking alike. That's why malignant tumor is just like our normal cell, no differentiated. But malignant tumor, they have differentiated. We can differentiate it with the normal cell. Then growth limit, they have limited growth, they are encapsulated, they have growth area to a particular localized area. But the malignant is unlimited. Growth rate of malignant is slow, it grows slowly over the years. But malignant grows at very fastly, within the week or within the month it grows. Then invasiveness, malignant is non-invasive, mean it doesn't spread, but the malignant is spreading, it is invasive and destructive. Metastasis, this malignant is not metastasis, mean it has normal cell division and the slow cell division, while malignant is metastasis, it has abnormal cell division. Mitotic figures, it has rare mitotic figures, mean it has normal cell division and which is the slow division, while malignant has sometimes numerous atypic division, mean it has rapid or uncontrolled cell division. Cell size and its shape is uniform in case of malignant. Okay, while it is pleomorphic, mean it has irregular shape in case of malignant. So this is the difference between the two types of tumors, and I hope that you understand the difference between them. Okay, guys, now we rapidly discuss the things that are written in the book because the lecture is become quite too long. But I have tried my best to make everything understandable for you. So, how you treat? First of all, the drug doses that are calculated on the basis of the body surface and the area where the patient has the tumor. First is the log phase phenomena, destruction of the cancer cell by the chemotherapeutic agent. Follow the first order kinetics, mean it is the first order in which when you give the dose to the drug, it depends upon the constant fraction of the cell. The term log scale is used to describe this phenomena. For example, diagnosis of leukemia is generally made when there is about 1 10 to power 9 of the leukemia cells are there, mean 1 gram. So consequently, it treats lead to the killing of 99.99% killing, and then इतने परसेंट मीन 0.001% of the cell, which is about 10 की power 4 of the cell remains. सो सिंपली मैं आप लोगों को इसको आसान वर्ड्स में समझाती हूँ. वो कहते हैं कि फॉर एग्जांपल लोग किल फेनोमेना क्या है कि आपके जो सेल्स हैं कैंसरस सेल्स वो किस तरह से मरते हैं. वो एक फेनोमेना है जिससे मरते हैं. लोग किल फेनोमेना इसको कहते हैं. अब लोग किल हम इसे क्यों कह रहे हैं क्योंकि जो ट्यूमर्स की कॉन्सेंट्रेशन है वो लोग फेज में इंक्रीज या डिक्रीज होती है. तो जब आप लोग लाइक आपको लिकीमिया हुआ. लिकीमिया ये कैंसर की टाइप है जो कि हो जाती है किसी भी ब्लड फॉर्मिंग सेल से. मतलब आपके ब्लड सेल्स नहीं बन रहे होते आपके बोन मैरो के अंदर. वो इस तरह का कैंसर हो चुका होता है कि वो कोई भी ब्लड के सेल्स यानी रेड ब्लड सेल वाइट ब्लड सेल वो नहीं बन रहे होते. सो ल्यूकीमिया हुआ और एंड इट इज़ डिटेक्टेड बट इट बिकम 1 gram mass means it has 10 की power 9 of the cells. Now after the detection, after the symptoms appear, you will start the chemotherapy, and the chemotherapy kills the 99.99 percentage of the cancerous cells. But 1% mean total 0.001% of the cells remains, which becomes 10 की power 4 of the cells. Okay, so this is defined as the 5 log kill phenomena, reduction of 10 की power 5 cells. Okay, so this is the 5 log kill phenomena in which you have reduced 10 की power 5 of the cells. At this point, the patient become asymptomatic. Patient has no symptoms, but you still have to give the drug to the patient. For most bacterial infection, a 5 log reduction in the number of microorganisms result in a curative. The immune system, because the immune system can destroy the remaining of bacteria cells. Mean they are saying that whenever you have the bacterial problem or bacterial infection, you give antimicrobials and they destroyed log 5 of the cells of the microorganism. The remaining 0.001% is destroyed by your immune system. But in the case of cancer, the remaining 0.001% they are not destroyed by your immune system. Because if our immune system can able to destroy the cancer cell, then we no need to make the anti-cancerous drug. But our immune system cannot destroy it. That's why we are starting the cancer therapy. So, however, tumor cells they are not as ready eliminated. Additional treatments required to eradicate them. Pharmacological centuries. Leukemic and other tumors find sanitary in tissues such as central nervous system, where transport to the curtain prevent the chemotherapy agent from entrance. That's why the patient may require irradiation of the cranospinal axis and the intrathecal administration of the drugs to eliminate the luminatic cells at that size. Similarly, drug may be unable to penetrate contain areas of the solid mass. So they are explaining that कि बहुत सारे इस तरह के ट्यूमर्स होते हैं जो सेंट्रल नर्वस सिस्टम में हो जाते हैं. Now you have explained that in the central nervous system there is blood-brain barrier that doesn't allow a lot of drugs to enter. So that's why we will supply those drugs through the intrathecal route. Treatment protocols, we have to give the combination. We cannot give single drug. Combination is important because cytotoxic different toxicity होगी, different जगहों पे एक्ट करेंगी और ज़्यादा साइटोटॉक्सिक इफ़ेक्ट्स आ जाएंगे हमारे पास. और और इसके बहुत सारे एडवर्स इफेक्ट भी हैं. एडवांटेजेस कम्बिनेशन के क्या हैं? प्रोवाइड द मैक्सिमम किलिंग ऑफ द सेल विद इन tolerated range, effective against the broader range of the cells, heterogeneous, may declare or prevent the development of resistant cells. Treatment protocol, many treatment cancers have developed. So the treatment protocols which we are following is called as RCHOP. Okay, is used for the treatment of non-Hodgkin lymphoma. Okay, so this is R for rupium, C for cytophosphamide, H for hydroxy, daunorubicin, O से oncovin, and P for prednisone. So this treatment is scheduled. Okay, guys. So is scheduled intermittently allowed to recover and rescue. Resistance, how the resistance is going to be occur. So resistance is occur in the neoplastic cell inherited because of the anti-cancerous drug. They are resistant, they acquire the resistance particularly due to prolonged administration. When you give prolonged administration, they become the resistance. So multi-drug resistance can occur. So that's why what you have to do, and they can have the toxicity of bone marrow, buccal mucosa. Okay, guys, so they have explained that the multi-drug resistance occurs due to our transmembrane protein which is a P-glycoprotein. इसकी वजह से हमारे पास resistance हो रही होती है इस प्रोटीन की वजह से. The resistance is due to adenosine triphosphate dependent pumping of the drug. ठीक है, ATP, ये जो पी ग्लाइकोप्रोटीन है ये ATP पे डिपेंड होता है ड्रग को आउटसाइड करने के लिए. सो जैसे ATP मिलता है वो ड्रग को आउटसाइड कर देता है और रेजिस्टेंस यानी ड्रग को सेल के अंदर नहीं जाने देता. फॉर एग्जांपल सेल दैट आर रेजिस्टेंस टू द अनरिलेटेड एजेंट्स. For example, the cells that are resistant to the cytotoxic effects of Benca alkaloids. Benca alkaloids ये एक टाइप है एंटी कैंसर ड्रग की. अगर सेल इसके खिलाफ रेजिस्टेंस बना लेते हैं लाइक इस ड्रग के साथ या इस ड्रग के साथ, these drugs are naturally occurring substances which are hydrophobic in nature. पॉजिटिव चार्ज होता है न्यूट्रल pH पे. पी ग्लाइकोप्रोटीन जो है ये एक्सप्रेस होती है लो लेवल्स ऑफ मोस्ट सेल्स बट हायर दे आर फाउंड इन किडनी, लिवर, पेंक्रियाज एंड स्मॉल इंटेस्टाइन एंड एड्रिनल ग्लैंड. सजेस्ट दैट द प्रेजेंस ऑफ पी ग्लाइकोप्रोटीन अकाउंट फॉर द रेजिस्टेंस कर देता है. सो इन जगहों पे ई फ्लक्स हो जाता है एंटी कैंसरस एजेंट का. जस्ट उन्होंने यही बात की कि जो पी ग्लाइकोप्रोटीन ये एक ट्रांसमेम्ब्रेन प्रोटीन है जो कि रेजिस्टेंस की रिस्पॉन्सिबल है, इसी की वजह से रेजिस्टेंस हो रही है. और दूसरी इंपॉर्टेंट चीज़ उन्होंने कहा ये जो पी ग्लाइकोप्रोटीन है ये ज़्यादातर इन जगहों पे पाई जाती है, हायर है. ज़्यादातर सेलों में ये नहीं है, लो लेवल पर है, लेकिन किडनी, लीवर, पेंक्रियाज, स्मॉल इंटेस्टाइन एंड एड्रिनल ग्लैंड में ये ज़्यादा है. सो दैट्स वाई वहाँ पर ये ई फ्लक्स कर देगी एंटी कैंसरस एजेंट्स का. एंड इट्स टॉक्सिसिटी विल अकर रैपिडली डिवाइडिंग सेल्स पे ये इफेक्ट करती है और प्रोलिफरेशन से रोकती है. बट इसकी जब टॉक्सिसिटी होगी तो सेल्स ऑफ ब्यूकल म्यूकोसा ख़त्म हो जाएंगे, बोन मैरो, GIT इफेक्ट्स, हेयर फॉलिकल्स ख़त्म हो जाते हैं. मतलब ये क्या करती है कि बोन मैरो के सेल्स रैपिडली डिवाइड होंगी, ये उन पे भी टॉक्सिक इफेक्ट, ये उन्हें भी ख़त्म कर देगी. हमारे हेयर फॉलिकल्स रैपिडली डिवाइड हो रहे होते हैं, ये उन्हें भी जाके इफेक्ट करता है. बहुत सारे एडवर्स इफेक्ट हैं जो सब एंटी कैंसरस एजेंट के एक जैसे हैं. फॉर एग्जांपल नैरो थेरापेटिक इम्पैक्ट्स होता है, वॉमिटिंग ये बहुत ज़्यादा करते हैं. सिमिलरली बोन मैरो सप्रेशन, एलोपिकेशिया हो जाता है, वॉमिटिंग, अगेन माइलो सप्रेशन, अगेन वही चीज़ उन्होंने लिखी हुई है. सो वॉमिटिंग के लिए आप एंटीमेटिक ड्रग्स उन्हें देते हैं एंटी कैंसरस पेशेंट्स को. ठीक है, फिर कीमोथेरेपिक agents, whereas other adverse effects are confined to the specific agent like bladder की toxicity हो सकती है, pulmonary fibrosis हो सकती है bleomycin से, bladder की toxicity इन ड्रग्स से होती है, कार्डियोटॉक्सिसिटी हो सकती है डोक्सिरुबिन से. ठीक है, मिनिमाइजिंग एडवर्स इफेक्ट कैसे करने हैं वो यहाँ पर लिखा हुआ है कि साइटोप्रोटेक्टिव ड्रग्स आप लोग दे दें, रिमूवल ऑफ सम हाइड्रेशन दें ताकि ब्लैडर की टॉक्सिसिटी ना हो. बिकॉज मोस्ट ऑफ द एंटी नियोप्लास्टिक एजेंट दे आर म्यूटाजेंस और प्लाज्मोजेंस arise 10 or more than 10 years. So that's why probably most tumor develops from the response to the treatment strategies. So ये पी ग्लाइकोप्रोटीन उन्होंने बनाई है, ये 6 मेम्ब्रेन लूप है इसकी और ये ATP डिपेंडेंट होती है. सो ये क्या करती है कि ये ATP को कर देती है चेंज ADP के अंदर और जो भी हमारे पास ड्रग होती हैं, ये जितनी भी ये सारी एंटी कैंसरस ड्रग लिखी हुई हैं, तो ये ड्रग है एंटी कैंसरस, तो ये उसे उठाती है और सेल के बाहर यहाँ पर भेज देती है। अब ये ड्रग सेल के अंदर ही नहीं जाएगी तब तक कैसे इफेक्ट शो करेगी। सो पी ग्लाइकोप्रोटीन इस तरह से रेजिस्टेंस कॉज करती है। ओह सॉरी, आप लोगों को नज़र नहीं आया, आई जस्ट डोंट सी इट। So this is the 6 membrane P glycoprotein, and what it's doing, it is using ATP and convert this ATP into ADP। और जितनी भी ये एंटी कैंसर ड्रग हैं, ये सारी एंटी कैंसर ड्रग्स लिखी हुई हैं, उनका नाम लिखा हुआ है, हम ये आगे पढ़ेंगे, ठीक है, तो आपने इस बारे में परेशान नहीं होना। तो ये जितनी भी एंटी कैंसर ड्रग है, ये उन्हें उठाता है और सेल से बाहर भेज देता है। अब एंटी कैंसर सारी ड्रग्स सेल के बाहर अगर आएंगी तो इफ़ेक्ट कैसे करेंगी, वो डीएनए और प्यूरिन्स पायरिमिडीन्स उनको इनहिबिट कैसे करेंगी, नहीं कर पाएंगी, इसलिए ये इफेक्ट नहीं शो करती। ठीक है, इस तरह से पी ग्लाइकोप्रोटीन की वजह से रेजिस्टेंस कॉज हो जाती है। ठीक है, सो ये चीज़ें थी जो एक्सप्लेन की गई थी हमारे पास कैंसर के इंट्रोडक्शन के तौर पे, और मैंने कोशिश की कि मैं आपको सारा समझाऊँ, सारा लिपिनकोड की हर एक लाइन हम लोगों ने पढ़ी है और उसको डिस्कस किया है। सो आई होप कि आप लोगों को ये चीज़ समझ में आ चुकी होगी। और अगर फिर भी आपके पास कुछ कोई भी कन्फ्यूजन स्टिल इज इन योर माइंड, you can definitely ask to me and leave a comment for me and I will give answer to you. So take care, meet you soon in the next lecture with the next topic, and take care, meet you soon, Allah Hafiz.